So we'll start that recording now. And go ahead and just begin to talk a little bit about the format we're going to use for these sessions. These are intended to be interactive mentoring sessions centered around cases. And so at some point during the course of the mentoring, you may be asked to present a case if you have a case, or you may be given some materials to present those materials as a potential case and discuss some of the questions that might come out of that case. So it's participatory, and it's an environment where we all learn from each other. We say I'm a mentor, and that means that I'm not the know-it-all professor. We are all equal peers in this regard of being learner teachers and teacher learners in both of those roles. So I hope that you will embrace that and teach us things about your environment, even as we may be able to teach you a few things from our experience and our environment in our settings. We don't all face the same problems. And so that's why pathology, as I like to say, is very much a team sport, and you need a diverse mix of team members. Welcome everyone again, and let's begin with this first case, which is a discussion of some things that may have come out in the Bootcamp module. And I posed the question in the chat as to how many of you had started that module. If anybody has completed it, please let us know. But if you have questions also, you can feel free to put those in the chat or unmute yourself and ask the questions as we go along. So let's just see here. So going on to the first slide and just discuss this case. So this is kind of a process case to illustrate some of the processes in pathology, as well as some of the pitfalls and where problems can arise and how we uncover problems, how we deal with quality issues, how we deal with patient care as pathologists, and so forth. So here are the basic facts. One man, RM, is 68 years old, and he comes to the urologist's office because he has an enlarged prostate. Shortly thereafter, KS, who's a 55-year-old man, comes to the same urologist for a similar problem. Both of these patients undergo a staging procedure, which is generally a multiple needle core biopsy procedure. And those needle core biopsies are separately collected, put in formalin containers, and then sent to the laboratory with a request for a diagnosis. The younger patient has a biopsy report that comes back as adenocarcinoma, Gleason 3+4. It's present in 3 samples on the right side. And has a reasonably extensive size of at least 5 millimeters in one or more of the needle core samples. In contrast, the older patient, RM, he gets a biopsy report back that says benign prostatic parenchyma, no neoplasia. So here's our first discussion point. What are the implications of this diagnosis for these patients? For KS, what are the implications for that patient? So let me pick on someone here. Beth Hakami, can you comment and say what do you think the treatment would be for KS? Can you unmute yourself, Beth, and just sort of tell us what you think the treatment options or implications of these 2 reports would be? Beth Hakami?
I think the case may be from prostatic adenocarcinoma, Gleason score 3+4, because the age is higher than RM. I think like this.
Okay. So one may get surgery, one may or may not. depending on their symptoms and so forth. So,
uh, KS maybe the need the surgical remove because uh, Gleason 3.3 plus 4.
right.
For the yeah, for ER maybe the hormone no control
Okay.
because I think it's benign prostate hyperplasia.
Yeah.
Uh,
Very
Thank
good.
you.
Very good. Very good. And I apologize. Some of you, I'm sure, have very little experience with prostatic disease because I know in Asia, prostatic disease is much less prevalent than it is in the United States. But the intent is not to go into those details so much as just to be aware that there are differences in management. And so these two patients do have different uh, treatments. Uh, KS, the one who had the biopsy of Gleason 3 plus 4, undergoes a radical prostatectomy 3 weeks following that first visit to the urologist. And that prostatectomy report comes back benign prostatic hyperplasia, no malignancy. Prior diagnosis, the prior slides were reviewed and confirmed. So we have a discrepancy, don't we? We have a discrepancy of the biopsy and a discrepancy of the final pathology. And that, in most situations, should trigger some questions. How did that happen? Is this a true result? Or was there something else that uh, came along that got in the way? So let me ask another of you, what do you think we should do next? So Egshiglen, would you care to comment on what the next steps would be? I believe you're coming from Mongolia, if I'm correct. Can you unmute yourself, Egshiglen? Egshiglen? Well, I'm not hearing anything. So maybe Chandrina from Phnom Penh?
Yes, good morning, Professor. This case, I have no idea what to do next, Professor. Yes.
Okay, that's an acceptable reaction. How do we sort this out? How could we figure this possibility? Well, one way, of course, to confront a problem like this is to say, what could have happened? How could we explain this? So, could there have been a mix-up between the biopsies of this patient so that the biopsy was not really his? Or was there some other source of exchange? And where can that sample mix-up have happened? So in the processes in pathology, we tend to think of three big categories of where errors can occur. So they can occur in the before it gets to the laboratory, the pre-analytical stage. They can occur in the analytical processes that happen inside the laboratory. And there are several of those, right? You're aware of the workflow in pathology. There's a couple of times when tissue is not always labeled. We don't have RFID chips in the tissue, for example. It goes in a container. And so in transferring from one container to another, or from the block to the slide, or other such steps, you can sometimes switch things if you're not very attentive or not doing the right process. Likewise, when the case is being put together with the paperwork and so forth, sometimes the paperwork gets mixed up with a different set of slides, and if the pathologist is not really aware, they can be looking at one patient's name on the paper and a slide that they think is that patient, but it may not be. So that can be a possible process. If we use a dictation system, sometimes the person who's doing the dictation may select the wrong patient from the list of possible reporting patients and type the answers or type the diagnosis under the wrong patient report. So there are a number of areas within that. Now, actually, that dictation, that may be a post-analytical sort of error, transcription error. And sometimes things get put in the wrong chart. If you're on a paper system, sometimes that can lead to a discrepancy in where things get filed. And I certainly grew up in a system where you use paper reports, and it was common to find op reports in the wrong patient chart or progress notes in the wrong patient chart, let alone lab reports. So those are all possibilities. So thinking of those, I think the next step is to kind of look at our process with the patient's sample and within our own system, figure out how vulnerable we are to any of these processes. Now, obviously, the laboratory has control over the analytical steps. We don't have a lot of control over what happens to that sample before it gets to us. And we may not have as much control as we'd like on the post-analytical, the stuff that happens after the report leaves our department. So in pathology, we tend to focus a lot on the analytical errors, but the reality is that the majority of significant errors of this sort happen before the sample gets to us in the pre-analytical stage. And so some investigation in that area and some process improvements in that area oftentimes bear the greatest results. I think with this case, the first question was, did we have tissue from the same patient and we just couldn't find the cancer? Do we need to go back and put through the rest of the entire specimen of the prostate to find that cancer? Or were we dealing with different patients that had been mixed up? And one of the ways to do that, and it's not universally available, but in this particular case, we did have the option to do genetic testing. And this is testing that can be done, so-called tissue identity testing, which is able to, on the basis of microsatellites or single nucleotide peptide or single nucleotide polymorphisms, et cetera, to characterize whether things are a match or things are not a match. Now, you'd not to have to do this very often, but the situations where it comes up are such as this, where you have a major discrepancy between a biopsy and a resection, or when you have perhaps a single fragment of tissue amongst a number of other tissue fragments that you cannot be certain belong to the same patient. And so specimens that, for example, get contaminated at the time of microtomy from the water bath, for example, little fragments of somebody else's tumor floating on the water bath shows up on the wrong patient, but it looks different. You're not sure. The patient didn't come in with symptoms suggestive of cancer, but you don't want to miss an occult opportunity to detect something early. So you may be compelled to either do a repeat biopsy, or if that's not reasonable, to do this genetic testing option. And here maybe I'll just invite comments from our other mentors if they have any experience with this type of an issue. Esther or Dana, do you want to comment on this?
Yeah,
Oh,
go ahead. So it actually happened a few times in our lab. It's not also something that we've done. I mean, we've switched samples, but sometimes it comes from a container, and it's difficult to really pin down where the mistake happens. But the final result, we are able to confirm the tissue or the diagnosis was, for a different patient or not. So that gets sorted out with the DNA testing, but it's always uneasy feeling when no one's clear on where the mishap happened. But there's so many variables along the way where the tissue travels from the patient's body to where we get on the slides and to the chart. Sometimes never find out because everybody says they did the right way. But the important thing is with the DNA testing, we can actually, say this was right or wrong. So that's always a comforting thing at the end. Dr. Regano?
Yeah, I was going to comment that I had a similar case that I thought might have been switched in this exact scenario when I was a resident and I had grossed them. And they were prosthetic tissue chips, and we weren't sure if I had switched them. Of course, I was extremely nervous. So the best thing to do when you're going into residency and you think maybe you made a mistake, maybe there's something going on, be as open and transparent about it as possible. Talk to your attending. I talked to my attending. I said, there's a chance I could have mixed this up because I grossed these right. I know I grossed these one right after the other. So I told him, we ended up putting the rest of the tissue through. Turns out I didn't make a mistake, but that will allow you to sleep at night. The second time I'm aware that this happened actually to a pathologist that I was working with at the VA. It was actually because a pathologist had come in just carrying prostate slides, showed him for concurrence, because every new malignancy you'll get concurrence, accidentally left the slides in that pathologist's room. It got mixed into a benign tray of a different patient. And unfortunately, that patient with benign prostate did get a prostatectomy. So you have to be so careful as a pathologist, starting when you're a trainee, because these things are just so likely to happen. It's crazy. You go through thousands of samples and they're all fine. And then there's these like tiny, minute times that you can get really caught up into a major mistake.
Yes, this is a sobering case to begin with, but that's part of our purpose is to emphasize the importance of being very meticulous, being very consistent, and very robust. And when we did the evaluation on this patient, in fact, we discovered that the prostatectomy specimen did not match the biopsy specimen on DNA analysis. However, because of our investigation going backwards, we discovered that that day there was only one other prostatic biopsy submitted. So there was no other chance. There was only one other, and that was from the other patient from the same office. So we were saved a little bit in that regard, and we didn't have to do an extensive panel of other patients to discover the switch. But this emphasizes the point that these identification errors often come in pairs. And when there's a major mix-up of sorts, you always have to be asking the question, where is the other side of this error? Where did it happen? So as a result of that testing, we had a number of implications. Well, we had another patient who needed a prostatectomy who previously thought they were scot-free, and we needed to provide some recompense and apology to the patient who wrongly had the prostatectomy. And we'll talk more about this sort of disclosure issue here in a minute. But I want to just use this to introduce a concept in terms of evaluating these kind of processes. Now, it's very easy sometimes, and in some cultures, to blame the individual, to blame the resident, or to blame the nurse, or to blame the laboratory for the error. But in reality, usually the problem is not the person, but the structure of the system. And this is where a technique called root cause analysis, or RCA, comes into play. When you have an event like this, you need to start asking the questions, not just why did this happen, but how could this have happened? What were the factors? And those can be factors on a variety of paradigms or a variety of axes. So it could be just the way your laboratory is set up, that you manage and you put all the prostate cases together. Well, that may not be the best process because that may set you up to make a mistake. You need to look at your machines, and in fact, there are now people developing automatic embedders and so forth that can eliminate that chance of there being a mix-up at the time of embedding. We now do staining with just one slide on a tray rather than one slide or a batch of slides in a water bath or a stain bath, because sometimes things float off slides and onto other slides. Those kinds of things. And then we have to ask the question of whether or not our personnel are properly trained to do the kinds of things that they're trained to do and that they need to do in order to do things right. And usually if we start asking these kinds of questions, we'll begin to come up with some contributing causes and some contributing factors that may be the sort of things that open up avenues to change. Because the last thing we want to do is to have this happen this week and then happen again next month or next year because we didn't fix this process. And so doing a root cause analysis, anytime you have a significant error or even a near miss, is an opportunity to learn. And I sort of summarized that in this slide here. You avoid blaming the person or embarrassing them, shaming them for making a mistake, but rather you look for the lessons, the opportunities to change the systems or the process to make it better. Now, sometimes people have said, well, we just will add a double check to things. And that temptation, while it's a possibility, it's much better to do things right from the start so that you don't have to have somebody come along behind and say, oh, you messed up on this, you put this in the wrong hole, et cetera, et cetera. But it's just obvious to the person that they haven't done it right and they can fix it before it goes on to the next process. And finally, you want to be able to design your processes so that mistakes are harder to do than doing things the right way. An example of that for me is how these three-pronged plugs are designed. If you look at a three-pronged plug, either in the English Western system or in the 220 system, there is only one way that plug can go in the socket. You cannot put the ground line in the power line because it's designed so that you can't make a mistake. You can't do it wrong. And the more that we can do that same sort of process with our pathology processes, so that it's hard to do things the wrong way, the better off we will be as we think through these processes. So that's sort of a thought about sort of how we work through this process. Let's come back to the patient. So how are you going to have the conversation with the patient on this issue? So here's a couple of thoughts. And this is, I realize this is not a basic topic in terms of patient disclosure of errors, but it is the matter of great professionalism to be able to do this. So thinking about who's going to be involved. In general, pathologists oftentimes tend to hide a little bit in the laboratory and are not involved in disclosure too much. But whenever the pathology laboratory is potentially the source of the error, or the hospital is potentially the source of the error, the pathologist should definitely be involved in this process. So you shouldn't just tell the urologist, well, tell your patient, that you messed up, da, 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 da. You have to be involved in the process, both to properly present a balanced picture of what happened, and also to better explain how it might have happened. Because to the urologist or the surgeon, the laboratory sometimes is just a black box. It's a complete mystery. What goes on there, I don't know. They take things, they get numbers out, they get reported, et cetera. They don't understand the process. And so you need to be present to be able to answer the questions that may be present, and also to defend your integrity and so forth. In general, this sort of disclosure should occur face-to-face, and not by some letter or phone call or something of that sort. Zoom, maybe, in some situations, but ideally face-to-face. And I think it's appropriate to include some empathy for the patient. That includes an apology. And then more importantly, from my experience, the patients, they know they will have suffered harm. But what will make things feel better for them is if they know that that has resulted in an improvement in the process so that other patients won't be adversely affected. And that's very, very powerful. If you can explain to them how this raised your awareness and you fixed this process so that it would not happen again. We don't always anticipate how these various things can happen in advance. And, errors are very creative. They find that one little loophole through our process to be able to occur. But having occurred, that is our opportunity to learn and to correct it. And for many patients, that's enough. Now, they may want some sort of compensation and so forth. That's a whole different discussion, and we won't go into that today. But I think it is important to understand that appropriately communicating what has been learned from the experience is very important for the patient. So in this particular case, what happened? Well, we discovered in our laboratory that since there were only those two patients evaluated, and since those two samples in our case log were handled at different times by different people who did the grossing or did the embedding and so forth, that we have a log of that sort of activity in our laboratory, case by case of what is done. And it's somewhat automated now, and that's very fortunate. But because of that, we could document that there was no time when those two samples were in close proximity to one another. From the time they entered the door in our laboratory to the time the pathologists who signed them out, and they were different pathologists in this particular case, there was no opportunity within the laboratory for those two things to have happened. So the only choice or the only option was that this happened in the urologist's office. Well, as we talked to their staff, we discovered that they had a number of habits which set them up to make this sort of mistake. So his staff, when they looked at the number of patients who were coming in, if it was going to be a busy day, they had various things, they would look at who was coming for likely biopsies and so forth, and they would create the specimen containers for those patients in advance. And then, this is the second error, they only had one procedure room in that urologist's office. And so all of the sample jars for that day were put in that procedure room. So there you have a patient coming in, but you have multiple possible choices for where their specimen's going to go. And then secondly, there was no timeout process that was followed in that office prior to doing the biopsies to verify that the specimen jars, the patient, the site that was being operated on, and so forth, all matched, and that there was no chance for mix-up. Now, as a result of this experience, we instituted a number of changes in not just in our outpatient offices, but also within the procedure rooms in the hospital to make sure that at the time of the timeout procedure, when they verify the patient identification, the procedure that's being done, and so forth, that there were no other labels in that room, and that there were no other patient materials anywhere in that procedure room that could potentially get crossed over into that patient. So this was a very unfortunate circumstance for the patient, but it allowed us to improve the procedures for many subsequent patients, not just in urology, but in other disciplines as well, in gastroenterology and pulmonary medicine and cytology and so forth, so that we could provide a safer environment for our patients. A number of things that can also be thought of as ways of avoiding these mistakes of identification are also highlighted in this process. So that single piece flow of just doing one specimen at a time is very important, that you only have one specimen jar open at a time, one cassette, et cetera, group open at a time, and you're only handling one slide case or one block at a time. You're not batch labeling your slides and then doing multiple sections on every block and so forth. Additionally, using dual identifiers for various patients is also very valuable and a way to make sure that you've double identified the patient. This is particularly important in some cultures and some settings where names may be quite similar. Now, I know many of you are from Vietnam, and you all are very aware that the number of surnames in Vietnam is much more limited than it is in other locations. So a surname like Nguyen Van Nguyen could be had by several different people of even the same age and town at various times. So you have to be very cognizant that you have a second identifier, a birth date, or another identifier as well. When I was in training, our hospital had the habit of having an accession number, which was sequential, but also assigning each case a different check letter that went on the label so that it was, 25-D-1234. And then the next case was 25-A-1235. So you had two opportunities to make sure that you weren't dealing with a sequential case issue. You had that check letter in the process as well. And then finally, as Dana's comment illustrated, being cognizant of when you're doing similar cases in sequential order, that may be a setup for problems. So sometimes mixing in skin biopsies with prostate biopsies, or mixing in other kinds of specimens in between specimens of similar type can help you to avoid that. And that's also true at the time of sign out. Although many institutions have instituted a specialist sign out, I just sign out GI cases and so forth. So it's very easy for them to have multiple gastric biopsies. But to avoid the possibility that I pick up one gastric biopsy from the box and sign it out for the wrong patient, we now just put our cases in a single box. So one case, one box, one requisition, and so forth. And that was, again, unfortunately, something that grew out of a learning environment where we had a mistake. And that opened up the possibility for learning again from that. So one of my colleagues in Vietnam worked on a nice topic for path outlines on risk management, and this sort of touches into that topic area. So if you want to do some additional reading, go to Path Outlines and look up lab administration, risk management, and you'll be able to learn even more about some of these issues in quality management. So at this stage, we're going to maybe divide up into some breakout rooms and let you discuss some additional questions relative to some of the content in the Bootcamp module about around some of these sorts of issues, troubleshooting problems in the histology laboratory and so forth. So I am going to, let's see, create some breakout rooms, if I can remember how to do this. And Dana and Esther, do you want to be in separate rooms or together?
Let's see, we have 22 people. What do you think? Probably just make it easy, go together.
Yeah, okay, let's do it. We'll create 2 breakout rooms and put you 2 in that. And I'm just going to start sending people to the breakout rooms. Oh, no. Okay, yeah. Let's see. Oh, Esther, I'm going to move you to the other one. Okay. All right, so all the rooms are open, and you should be going to those breakout rooms shortly. And we will close at the top of the hour in the breakout room. So once you finish the discussion, you can just close that. Okay, well, welcome again. It's good to be with you. And let's just sort of, first off, do any of you have any comments or questions about either what we've talked about in this case or about anything in the first modules that you've begun to work on in the open platform? And that can be really any kind of feedback. If things that were good, things you didn't understand, or things that were hard to work through. Any problems encountered by anyone?
Oh, hi, Dr. Castle. Beth Hakimi here.
Yes,
I wanted a suggestion for maybe like a summary or a guide for selecting stains or like kind of like developing an understanding for the sequence of ordering them. I have seen an issue previously where a lot of unstained slides get produced but not used. And sometimes that's a problem because like of a protocol for a certain case, and sometimes it's needed, but once they need the unstained ones, they will not find them, then they have to look for them. So maybe offering a little bit of guidance about understanding the stain sequence. So say like you start with this, then you go to this, or maybe like a summary about what stain is for what, if possible. Thank you.
Yeah, so that's a good comment and question. It's easy. It's probably harder to answer than it is to ask, of course, because so many cases are quite distinct in terms of the question that you're using, the question you're trying to answer by using stains. So, for example, you may have a 3 or 4 differential diagnostic considerations for a tumor, and 3 of them are very common and 1 is extremely uncommon, or 2 of them are common and so forth. And so the circumstances or the sequence in which you might use stains might be reflective of the relative frequency that you expected with a particular stain's positivity. It might reflect what you have on your menu and what you're familiar with, as well as how much the patient can afford in terms of total staining. In some situations, the patient has to be queried or their insurance has to be queried as to whether or not the cost of that additional staining is going to be covered. And so you may be in a situation where you're doing limited stains based on can we get the diagnosis and affirm the diagnosis with just these 2 stains, even though we've got 3 other possibilities on the differential diagnosis. So it can be quite variable in that regard. And so it's difficult to ascertain. I will say that the Pathology Outlines site has a quite thorough listing of the various special stains, immunohistochemical stains, and discusses some of their uses by pathologists. And so that can be a good resource to evaluate. And that's obviously, it's open source, freely available. I have the good fortune of operating in a setting where I have access to ImmunoQuery. Our institution has an institutional subscription to that service, and I'm able to, from that, ascertain which are the highest value stains for a given differential diagnosis and so forth. But that sort of an algorithmic approach may not apply in your situation if you don't have a subscription. So those are the tools that I would use in approaching that question. Your comment also about the nature of unstained slides being misfiled or lost or forgotten about is a pertinent one because you do have to have in your system some sort of mechanism to manage those, either filing them with the rest of the case or have some other sort of listing that tissue is available. The pathologist is often termed the steward of the tissue. And so being able to maintain that stewardship is very important for you. And being a good manager of that tissue. So for example, when we receive a request to send tissue for molecular analysis and so forth, we determine whether there is sufficient tissue or whether it's going to be a waste of their time and money, because we don't want to necessarily waste that tissue if it's not going to be fruitful. So if we don't meet their percentage tumor requirement threshold, then we would say, don't send it. That's a waste of the patient's money. It's a waste of what little tissue we have remaining. So those are all important questions. So the couple of the discussion questions, and I know some of you are more experienced than others, but let's just discuss some of the issues relative to grossing. And maybe some of you can tell me whether or not you've had any experience in grossing tissue. Have any of you done tissue grossing? Just raise your hand or something of that sort. No? So when we do grossing, and we cover grossing topics in each of the various organ system modules, it's very important that the tissue sample be well fixed. And formalin fixation is something that happens over time. It's diffusion related. And if you have tissue that is thick, in other words, more than that 2 to 3 millimeters in thickness, it's very possible that the fixation is going to be uneven. And this is one of the problems with larger specimens and why they're often fixed overnight. is so that you have enough time for the formalin to penetrate the tissue. In general, a rule of thumb is that formalin will penetrate tissue at about a rate of 1 millimeter per hour of fixation. Now, that is partly concentration related and so forth. But for most formalin containers and so forth and organs, 1 millimeter per hour is a good gauge. But that is significantly impaired if you have things like a serosal surface involved. So if you put a uterus that's say 10 millimeters, 2 centimeters in depth into a water bucket, or excuse me, into a formalin bucket, because there's serosa over most of that uterus, it's not going to reach the endometrium for a much longer time. And that, of course, is a problem because usually it's the endometrium that we're interested in. And if that's poorly fixed, then we can't make a diagnosis as well as we would like. So we open the uterus and then we fix it. We don't just leave it in the bucket overnight and say, we'll get to it tomorrow. We have to do certain things to open the specimen to allow formalin to get access to those mucosal surfaces. The same is true with bowel. You have to open that, clear away the mucus and the feces and so forth so that you get good mucosal fixation. So another question is, here I've asked a question, what happens if your alcohols in your overnight processor, or if you're doing frozen sections in your frozen section stainer, are old and they've been contaminated with water, so that the absolute alcohol, instead of being 100%, is now maybe 90% or 85%. What are the implications of that for your tissue process and your sections? Does anybody know? Dr. Saad, you know? Dr. Bun?
Hi, doctor. So I think how the water can retain in the tissues.
Yeah, so the water will stay in the tissue. It won't become dehydrated. And that's the purpose of your alcohol, is to dehydrate that. So what happens when the tissue has water still in it? When you try
So
to
the tissue can be soft.
Yeah, it will be too soft, and it won't take up the stain properly. So it will look abnormal, and you'll have difficulty with the process. So how often should you change those solutions, those alcohols? Do you think?
I don't know.
Yeah, I know. So it depends on how much you're processing, how long it's been there, and so forth. If you've just done one frozen section this week, you may not need to change that for a while. But if you're processing lots of tissue through your processor, you may have to change it every day or two to do that. And so that's one of the challenges. Now, it's interesting that this would come up because actually there are some potential changes on the horizon that will allow us to do direct microscopy from a fresh tissue sample and using the autofluorescence characteristics of tissue to be able to generate an H&E-like digital image. In other words, no processing, no staining, no chemicals, just tissue, light, and some manner of detection and processing of that image can render an image that looks like an H&E image and is actually interpretable and manageable by other things. So it may well be that in the course of your careers, that all of this histology, or at least some of this histology, will become just a sideline for some of your work. How that will all play out is yet to be seen, but it's certainly an interesting change on the horizon. So what happens if tissue is put into decalcification solution? What happens then? What do we use for decalcification of bone or other calcified tissues? Does anybody come across that? V, have you come across that in your experience in Vietnam?
Hi, Professor.
Hi.
I have across that situation, and I know we have to go into the decalcification process because the tissue is lots of calcium there, and the microtome cannot sac the tissue. And then we have to go into the decalcifying process. But when the process is prolonged and the tissue may not well fix in the tissue processing, and after that the actually stain will be I saw it stand darker and hard to interpret, and also it will some change in the protein that will interfere the immunohistochemistry.
Yeah, very good. The tissue has to be fixed first and then decalcified. And the way that we decalcify tissues, there are two primary methods. One is the use of a chelating agent, which is generally considered a gentler form. It's also a little bit more expensive and takes longer. And the second methodology is to use an acid that will change the pH and leach out the calcium, allowing that tissue to become sectionable. Now, sometimes you encounter a situation where you didn't detect that there was calcification in it. When they go to cut it, it's very brittle or scratchy and so forth. And they say, oh, there's some calcium in here, when it's already in the paraffin block. Your choice in that situation is to do what's called a surface decalcification, which is to actually take the block and soak that in a decalcification solution for a period of time to reduce and sort of leach out from the surface some of the calcium. And that can then make it possible to section that block without having to melt it down and then put it in decal and then re-embed it and so forth. So it can save a little bit of time there. Now, when you have over decalcified a tissue in acid, that also affects the nucleic acids. And so what happens is the hematoxylin becomes very pale. It has a very hard time to bind to those acidified proteins, or acidified ribonucleic acids. And so it actually, rather than getting darker, it gets very pale. And your tissue can be harder in that situation to determine, do I have a nucleus here? What kind of nucleus is that? And so forth. So we lose some of those clues that the usual staining gives us. Hematoxylin is what's called a stoichiometric stain. In other words, the more DNA there is in a cell, the more the stain will be taken up. And that's proportionate, directly proportionate one to another. And that's why cancer cells oftentimes are hyperchromatic in the nucleus, because there's more DNA in that nucleus, and so it takes up more of the hematoxylin stain. And that becomes a nice clue that there's a ploidy issue going on in that, or maybe there's amplification of various genes and so forth in that nucleus. And it's right there in the image in the H&E stain. And that becomes something to be aware of. Now, interestingly, that kind of information, we register with our eyes in certain ways, but some of the new techniques using artificial intelligence and image analysis can look at those kinds of features and with enough data can begin to predict certain molecular markers. So these are image AI-derived molecular markers that can be determined with some degree of accuracy based on a large amount of mostly unsupervised learning in that regard, or semi-supervised learning using some new techniques. Okay, well, we've covered those questions. We've gotten through the issues. We are going to repeat this session, or excuse me, we're going to repeat and have another session in 2 weeks and have some new cases. And if some of you have some questions in advance, that would be good to submit those so that we can bring those in for discussion. Any other questions before we wrap up?
Good morning, Dr. Hassel. So I have a question about the second question. So if the alcohol contaminated water, it will not stain well. So what happens after that for the slides already stained? You start over again or just use that slide, to diagnose the patient?
Yeah, that's a good question. Troubleshooting the stains requires a good relation with your histology laboratory and your histotechnology personnel. Sometimes they will identify that the stain is not working right because of a problem like this, and they will repeat it. They will change the solutions and they will repeat the process. Sometimes you have to reverse the process, destain the slide, and then change things up so that then you can restain and get a better process. Or you may have to get a recut and restain of that sample in order to make a diagnosis. Pathologists in general, after enough experience, become very adaptable. And we can look at staining differences and adjust visually in our minds, what's going on. But AI algorithms and things like that, they're much more rigid, and they don't do that very well. So it is important to try to work for a consistent stain, especially if you're going to use that for any sort of AI algorithm. But in general, in terms of pathologists, we tend to have the ability to adapt. And I see a lot of slides from different hospitals, different laboratories, and there's quite a range of what people like to look at. So the pathologist may tell their laboratory, hey, I like more hematoxylin. I like my stains to be bluer. Or somebody else may say, no, we like a nice pale, three eosinophilic colors and so forth. So eosin is supposed to have 3 different levels of pink, sort of an almost orange, a pink, and then a pale pink. And you should be able to distinguish those on the slide, but some places they don't emphasize that, and so they may be different. So there's quite a bit of variability in histology, and that's one of the things that you kind of have to learn to adapt and adjust, but it's part of the practice, I guess I would say, in that regard. Good question. Anyone else? Okay. Any other questions? Okay, I'm gonna just see, let's see. I've forgotten how to communicate to the other breakout room. Oh, actually, it looks like the other room has closed up already. So let's see. Yep. So I think we're just gonna end there, and we will see you again in 2 weeks. If you have questions between now and then, don't hesitate to send them in. Reach out. The contact information for Dr. Rosano is on there. You can always send something to open-pathology.org, and we'll get that as well. So thanks everyone, and we'll see you in a couple of weeks.
Thank you.
Thank you so much.
You're welcome.